evaluation is necessary and whether intervention is required might be challenging. And this is really what we are going to try to address today. So the objective for what we are going to do in the next maybe 30 to 45 minutes is to basically identify some of the basic pathogenetics mechanism of leukopenia, understand some of the relevant laboratory concepts, and understand the importance of integration of the clinical history, physical examination findings, and lab testing in the diagnosis of neutropenia. Basically, I will share with you what I really do in my setting, which I think a lot of it probably can be adapted in your practice and in the way you do when you see patients. And finally, we'll hopefully be able to distinguish by these combination of clinical and laboratory data the causes of neutropenia, and maybe advise some of the therapeutic. So just as a caveat, this may end up being very rudimentary or basic for some of you, so please forgive me for that if this turned up to be the case. But I will start at a very basic level, which I usually start with laboratorians. And then hopefully we'll ramp up into some of these conditions very soon. So white blood cells, we all know these are cells involved in the immune functions, and they are located in the peripheral blood, but they are formed in the bone marrow, and they will be circulating in the peripheral blood, but they also could be in tissue like lymph nodes in the case of the lymphocytes. These are the 5 major categories of white blood cells that we'll be talking about. Basically, the first step with any patients who walk in your clinic, or even I receive a sample here from you, would be the CBC, which basically a CBC differential. The differential provide both relative and absolute counts. So the neutrophils are the most common ones, which represent anywhere from 55%, around 55%, followed by lymphocytes representing about 35% of the cells, and then monocytes, which is ranging about 6%, and then the eosinophils and basophils are essentially minimal. The total white blood cell count, which is the first quantitative measure that we actually decide if this patient is normal or not. They normally range from 3,500 to 1,000 to 10,000. So anybody less than 3,500, we call this leukopenia. Again, these are the absolute numbers here for each category. It's 1,500 to 6,700. For example, neutrophils, we have to look at combinations of absolute number and relative number, because you may have you cannot look only at the percentage, and you cannot look only at the absolute. You may have 55% out of 3,000. That's going to be low. This is going to be below 1,500 for neutrophils, and it's going to be neutropenia. The one thing I want to point out here, when we are talking about the CBC, we have a normal ranges. These normal ranges differ from a location to a location. So if I'm a lab, even within the same country, these numbers will change, and we'll talk more about this. So your normal reference ranges is going to be different based on the population that you are dealing with. And we come up with this normal range based on your local lab in your area. So I used to work in Michigan before. There's a large African-American population. Our normal ranges were actually completely different than what I do now and what I did, for example, in Utah, where I have a different types of population. I might be in a city or in a country where there's a lot of Middle Eastern descent, and there might be a lot of thalassemias. Now my different ranges for the size of red blood cells is going to be different. And the way we generate these normal ranges in any given lab, we have to follow what they call the CAP, or the College of American Pathologists, recommendations for test validations, which essentially I have to go in the community and get 120 normal individuals, do their CBC, and then generate these normal ranges, sometimes even more than that. Now, let's start by understanding what do we get in this automated CBC. The white blood cell is determined by usually an EDTA, anticoagulated blood specimen, and EDTA is the ethylene diamine tetraacetic acid. It could be heparin. It's an equivalent to the heparin, but actually it's a specific anticoagulant. And there is an importance for this will come in a second, but just keep this in mind. Most of the CBC is done on EDTA specimen. Red blood cells are removed by lysis when they come in the lab, and then the total white blood cell is measured by, usually by electrical impedance or light scatter techniques, which I will show you in a second. The unlysed red blood cells, like nucleated blood cells or platelets clumps or large platelets or cryoglobulins, may result in spurious white blood cell results or the wrong white blood cell result. So this is really gives an idea for us, what do we mean by the automated evaluation? You will get something like this on a piece of paper that for, say, is the CBC. Basically, you would have, again, the percent of the neutrophils, but also you have the absolute number next to it. So even though in this particular patient, I may have the normal number, the percentage, the absolute count may not be normal. So we generate these numbers from the graph on the left side, and the graph on the left side is designed based on the volume versus the side scatter. So we know where the neutrophils come because they are in some specific area in the scatter, and we count those. The machine, the computer actually counts those, the machine, and then give you this absolute number, and then the percent is calculated based on everything. And then the same thing for lymphocytes, because they are different in their side scatter. Their feature, the neutrophils have larger volumes, they are bigger. They also have more granules in the cytoplasm, so they deflect the laser in a certain direction, and then what's recorded come in a specific area. This is a more explanation for how this is come. And again, in a second, you will know why I'm showing you this. So basically what we do, we lyse the red blood cells, and as I pointed out, we run the cells in a single file, as you see here on the left side. I hope you can see my arrow here. And then you hit those cells with a laser. The laser actually go through a combination of dichroic and filters and get detected by detectors, different detectors in the machine, based on the size, again, and the complexity of the nucleus and the granularity on the cytoplasm. And this complexity, basically, as I pointed out, the yellow ones here on the right side, or the orange ones, are the neutrophils. We know they are neutrophils because we know this is where the neutrophils come. Each cell becomes a point, and the blue ones are the lymphocytes, because now we know they have less cytoplasm, they have less complexity of the nucleus, they have less granularity in the cytoplasm. And this is how we make these numbers. So again, as I pointed out, many factors may affect the CBC parameters. If the patient have iron deficiency or thalassemia, as I pointed out, I have to adjust for those based on the location for normal, but also ethnic differences and minor infections, and even gender or pregnancy may change these based on dilutions and things like that. So white blood cells and the peripheral blood, the first step we already addressed is the quantitative. You look at quantitatively, are they normal or not? And then once we know they are decreased or increased, I try to look at qualitative, or now we need to understand the cause of the abnormal white blood cell presentation and pay attention to the clinical scenario and the differential count. Now, what happened at this point, once you get anything abnormal, we take a drop of blood, we put it on a slide, we smear it, and then this becomes the peripheral blood smear that I look under the microscope, and I can tell you there are some qualitative findings here that actually give us some additional points that I may be able to extrapolate further into, is this patient have disease A or disease B, and we may be able to suggest treatment X or treatment Y, and then you are going to make the final decision. This is really what I'm going to do with this patient. So we'll try to do some of this together. Now, I want to point out, this is the pluripotent hematopoietic stem cell diagram and the human body. And the upper half, it happens in the bone marrow, and the lower half after that line is actually peripheral blood. So all of these 5 cell lines that I told you, these are the mature cells that comes out in the peripheral blood. So what we do from reading what's happening in the peripheral blood, while we don't see what's happening in the marrow, we try to actually predict what really is happening in the marrow. And we'll give you some vignette at the end. Some cases will basically explain the point. So basically what I try to do, what I have done in the last 20 years of my life is I have spent time looking at slides and trying to learn from what I see in the peripheral blood and predict what's really happening in the patient body and in the bone marrow. So leukopenia, by definition, any white blood cell count less than 3,500. The majority of the white blood cells are neutrophils, as I pointed out, it's 55%. So whenever I receive a decrease in just the white blood cell count, even without the differential, it implies that the neutrophils are decreased, and it implies neutropenia. It's the most common cause of leukopenia. And actually, we're going to spend a lot of the time, the rest of the day today, speaking about neutropenia, because it's the most common cause of leukopenia. You may have other contributors to the leukopenia. The next in line is lymphocytes and monocytes, and these are very rare, much rarer, and we will spend limited time on it today. But it would be in condition where you get lymphopenia like in HIV or congenital immune deficiency or some causes of monocytopenia. But again, the most common adverse effect of leukopenia is, again, related to neutropenia. That's why we will focus on neutropenia. So what do we mean by neutropenia? It's an age-adjusted reference range, which differs for pediatrics compared to adults. And that's the reason why it makes a lot of difference that you make sure that the lab that's giving you a CBC, giving you the correct reference range for children. Magic number is 500 here. If you have less than 0.5 by 10 to the power 10 per liter, which equivalent to 500 absolute number of neutrophils, this is a significant risk of serious infection. And you have to have a parental antibiotics, and essentially here we would have the patient would be hospitalized immediately, because this patient would be walking out without protection basically in the street. So the clinical feature, we all know that, again, from the medical school, but we are going to review this quickly. The symptoms and signs of neutropenia are often related to infection, could presented with fever, chills, sore throats, painful mouth ulcers. Patient may present with malaise, but with agranulocytosis, which here we refer to granulocytes, neutrophils as granulocytes. Granulocytes, these are cells that have granules. Could be neutrophils, could be eosinophils, could be basophils. Any type of cells, white blood cells that have granules, which belongs to these three groups. But when we refer to a granulocytosis, we usually refers to the granulocytes, the neutrophils specifically, and mean the patient essentially have zero granulocytes. So infection, those patients are overwhelming, and often the patient will die in few hours, potentially a few hours, or may live for a few days, but usually in hours. So serious infections, as I pointed out, are more likely to happen when the neutrophils falls below 500 per cubic meter. So the pathogenesis of leukemia, this includes both malignant and non-malignant causes. They could be really related to either two major categories, either inadequate or ineffective granulopoiesis, basically are not performed, either suppression of the stem cells in the marrow. Usually, if there is a suppression in the marrow, usually accompanied by anemia and thrombocytopenia, you'll find other cell lines decreased. We would call this aplastic anemia, which basically a bone marrow hypoplasia, and it's a misnomer because people see aplastic anemia, they think, and the only thing is down is anemia, but it's actually all the cell lines. Or infiltrative marrow disorder like tumors or granulomatous disease. Many drugs actually can cause this, and we can talk about that. Some examples here. Chronic illness, ineffective hematopoiesis like neoplastic condition like myelodysplastic syndrome, or congenital conditions, as we will discuss shortly. And then you have an accelerated removal of neutrophils from the peripheral blood, or what we call peripheral destruction or consumption, which is the second big category. And usually these are immunologically mediated. We often call those idiopathic, where a well-defined immunologic disorders may be understood, as in systemic lupus or erythematous, systemic lupus erythematosus, or if we don't know the condition, then we call it idiopathic. Other causes also may include drug effect as well. Peripheral consumption could happen because of splenic sequestration of neutrophils, like in cases of hypersplenism. Also, increased peripheral utilization and margination could happen. So in circadian variation, circadian rhythm variation, or in some conditions like steroids may actually cause this change or variation. Also, overwhelming infection could be associated with consumption, peripheral consumption of neutrophils as well. So what do we do in a workup of neutropenia from, again, a lab perspective? What do we do as soon as I get a CBC that says that this patient had neutropenia? I immediately perform smear, as I showed you before. And the first step for me, I have to determine, is this true or spurious? Is this really a true neutropenia, or is it false? And we'll show you exactly what do we mean by that. And then we look at the clues for other diseases. Are there blasts? Are there teardrop cells? Are there signs of infections? If blasts, that may make me think of acute leukemia. If there are teardrop cells, then I may think, which basically it's a red blood cell look like a teardrop, which may indicate that the bone marrow has fibrosis. Or I may see additional signs of infection, which includes Dolly bodies and the neutrophils, or toxic granulations, or even vacuoles of the cytoplasm of neutrophils. We have been associating the increased granules and vacuoles and these toxic granules and neutrophils with actually severe infection. We see this more often in really sick patients or septicemic patients. We also look at the clinical history to determine the age of the onset. This is very important when the neutropenia happened, and we'll show cases in a second to see how important this is. We look at the medication risk lists. We actually look, we assess if this is acute versus chronic. And this is really what I do here immediately. As I see a case like this, I jump into the medical record and I go and I review the patient chart. I would look at your notes and the clinician notes or referral notes, and I would be able to answer all of those. And then I will put the picture together. And at that point, I may make recommendations based on what I will see. Do I need to do for you as a clinician? Do you do a bone marrow examination or not to evaluate the disease? So this is really going to be the work through that I'm going to take you through. And don't worry, it may look complicated, but actually I decided to put the very high level, the most common one, and a high level, and we'll take you one by one for, again, the next 30 minutes. So the first step here, as you see on the left side, is I want to rule out pseudo-neutropenia. I want to make sure this neutropenia, if I get you get a patient, you perform, you do a CBC, I get the slide, I can make a smear in the lab, and then I have to confirm this is pseudoneutropenia or not. So what's a pseudoneutropenia? Pseudoneutropenia, basically, as you see on the left side, you see aggregates of neutrophils in one area of the slide. And these aggregates, I showed you a couple of examples from cases that I had. And essentially, this is artificial. This patient is fine. This patient have no problems. And why is it important for us to identify this? I will explain to you in a second. So what happened on the right side, now you will understand why I have shown you the scattergrams from the either the impedance or from the flow cytometer, because what happened when these clumps of cells becomes very big, the computer is going to look at these and put them in a different location because they are big. They have more complexity, as they see with the arrow. They are not going to be host I would basically see giant granules, often round, red, blue, or gray granules, usually variable in size, and in cytoplasm of the leukocytes. They will be in the leukocytes, they will be in the eosinophils on the left side, they will be in the neutrophils on the right side, as you see this big chunk of vacuoles, and also in the monocytes and the lymphocytes. They will preserve the platelets, and megakaryocytes usually are not affected. This is poorly understood membrane abnormalities results into the fusion of the primary or azerophilic granules and to a lesser extent a secondary granules, which are the specific lysosomal granules. Usually cells have a reduced ability to kill phagocytized bacteria. And this is a rare, Shinya Higashi is a rare and fatal autosomal recessive disorder, usually characterized by these giant inclusions and granular body cells. Could be including skin or adrenal glands or CNS. The clinical findings may include partial oculocutaneous albinism with photophobia or nystagmatism and peripheral neuropathy, and occasionally and hepatosplenomegaly, and obviously with pancytopenia. The patients often come with lymphadenopathy and recurrent severe pyogenic infection. On the right side, you would see some of the abnormalities that I may see in the bone marrow, and I may think if I see something like this, which is essentially granules, you see a lot of granules on the myeloid precursors or early myeloid with a lot of these white granules there. And this would be indicative of or suspicious for Pearson syndrome, which is a mitochondrial disease characterized by sideroblastic anemia and exocrine pancreatic dysfunctions. So again, the point here is that we may see things on slides that give us clues to actually what's causing the neutropenia. Causes of neutropenia the list is long, and it's impossible for us to cover this in an hour or even a couple of hours. But again, as I said, I will cover only the most common ones that I likely think about, and also the framework that actually guide me through so I can answer any given case and I would reach a diagnosis at the end. So additional causes we need to keep in mind is collagen vascular disease, autoimmune disorders, isoimmune unital neutropenia. And this is where the mother would have the immunoglobulin IgG that crosses the placenta for the patient and cause the immune neutropenia. This could be caused in complement activation, patients who are in renal failure and they go through hemodialysis or ECMO. As I pointed out, hypersplenism, drug-induced or post-chemotherapy, and I have mentioned some of the potential drugs already. Obviously, nutritional deficiency, but often this is not isolated, and we'll talk more about this in a second. And then congenital disorders. So this is a list of congenital disorders. We are not going to go through these, so don't worry. I don't memorize them, and but I know some features about them that can help me. So these are labeled in groups based on if they are involves ribosomal dysfunctions or disorders of metabolism or disorder of vesicular transportation. And you can see some of them I have explained, for example, the Pearson syndrome, which is a mitochondrial DNA deletion. We discussed a little bit about Shinya Higashi syndrome, which again, this is a disorder of vesicular transport, as I pointed earlier. There are going to be some other disorders like dyskeratosis congenita or Schumann-Diamond syndrome, which again, there are certain morphologic features. I'm not going to bore you with all of these details. This is for me to worry about because this is what I do on day to day. But for you, you just have to ask the pathologist to follow these steps and they will be able to guide you in a certain direction. The one thing I'm going to point out is some of those, like cycling, many of those actually, essentially all of those, that's why I listed those here, they have specific genetic abnormality that can help us actually make the diagnosis. So, but we see features that guide us one way or the other, and then we do the specific testing that we can confirm the diagnosis. The one specifically I would highlight is the cyclic neutropenia. This is a patient who actually get into cycles every 2 to 5 weeks of cycling up and down of neutrophils, and usually they usually maintain their numbers at a certain range. And the way you diagnose these or you suspect them is basically you have to do the CBC for at least 4 weeks, every week at the same day at the same lab. Don't do it in different labs because you will get a different reference ranges, and you can see the cycle. It's basically you will catch it going down and going up. Those patients, you don't do anything to them, you just follow them. If they are severe enough, you may give them some GCSF. We can confirm sometimes if we have suspicions. We do the ALAN gene, ALA2 gene, the one that I listed here, which is a specific sequence. We have certain sequencing, and we actually can tell if the patient had mutation in this gene and confirm the diagnosis. We're going to keep moving along. The next, once again, this is the algorithm for me. I'm going to give you another algorithm at the end for you on the clinical side to do with the patient, but I'm just sharing with you what I do so you know when you send it to the lab and the pathologist, this is really what they do. The next, after I exclude the atypical lymphocytes and neutrophils, I look at if there is blast. I look at other cell lines like nucleated red blood cells, and red cells are their dacrocytes. And these basically will confirm for me if there is a primary bone marrow disorder. At this point, if I suspect this, then I have to go and do bone marrow biopsy. This is an example in the peripheral blood on the left side. And the peripheral blood, I should never see a nucleated red blood cells. This is a red blood cells that have a nucleus there. And the reason why I know this, because look at the cytoplasm. It started to make some hemoglobin. This cell should not have been in the peripheral blood. Something is pushing it out. I also know this patient is in trouble. Something wrong with it because there is a blast right underneath it. There is a myeloid blast. There is a cell with a nucleus and nucleolus that's staring at us now, and there's even cytoplasmic projection. So this patient have something likely bad, and this is where I will pick up the phone and call you and say, please do a bone marrow because we need to diagnose this patient. On the right side, I may see this is the teardrop cells that I told you about. If I see many of those that are pointing in different direction, there is one the arrow pointing to, I know that this patient probably have some fibrosis in the marrow, and now they need to do bone marrow fibrosis. The last category that I always keep in mind is the increased large granular lymphocytes. And why is that? Because it's very highly associated with the LGL leukemia is highly associated with neutropenia. And the way we diagnose this, we do flow cytometry. If I see these cells here, and it's very simple, as the name indicates, large granular lymphocytes. It's a large lymphocytes that have granules in the cytoplasm. There is no rocket science here. It's very simple for me as a pathologist. I look at it and I say, this is large granular lymphocytes, and there's many of them in the cytoplasm. The patient had neutropenia. I will do a flow cytometry, and this is a whole complete level of complexity that we deal with in the lab. But essentially, I will tell you from the flow, are they normal? Are they abnormal? Are there even clonality or not? And you may or may not do bone marrow there. So before I go further, I'm just going to open for any questions for what I have presented so far. If anybody have any question. And what we are going to do next, we'll try to answer some of these questions. What we'll try to do next, I have 3 cases, 3 patient scenario we're going to go through and see how we may be able to manage those patients. And then I'm going to leave you with an algorithm that I would use if I from the clinical facing side. So I try to put some of the pathology aspects or the lab aspect with the maybe the clinical aspect and go from there. So any question before we go further?
يا شباب، حد عنده سؤال؟ حد عايز يسأل الدكتور محمد في حاجة قبل ما يكمل؟ لو حد عنده سؤال واحنا في وسط الكلام ممكن يكتبوا لي في الشات وانا اسال الدكتور محمد.
ممكن مفيش مشكله. احنا almost we are done. We still have maybe 15 minutes to go through. بس انا يعني ما كنتش عايز اخلص البرزنتيشن كلها من غير ما اسيب وقت للاسئله يعني.
تمام. محدش عنده سؤال؟ واضح ان الموضوع مفهوم جدا يا دكتور محمد. حضرتك ما شاء الله شرحك لطيف جدا في الحته دي. الحته دي صعبه. انا اول مره افهم الرسومات اللي على الجنب دي. عايزه اقول لك ايه يعني، اول مره. ماشي، شكرا يا دكتور محمد، اتفضل كمل.
طيب for patient one, maybe I will leave you for a second to read this, but simply this is a 29-year-old patient from Ethiopia, came for evaluation of neutropenia. The patient had no significant past medical history, normal history, and the patient had not experienced any infection other than brief self-limited episode of sinusitis earlier this year since his arrival to the United States. 5 years بقاله 5 سنين in the US. His examination was unremarkable, and his primary care physician did a CBC and found that this patient had neutropenia, basically 28%. So remember at the beginning, I said 55%. This is automatically abnormal here. It's 28%, but still can be normal if this patient had, for example, a white blood cell count of 20,000, right? So this is why we have to look at the absolute. The absolute now is 1,100. So it's less than 1,500. This would be in the mild. Because it was abnormal, we performed a peripheral blood smear, which looked normal, completely normal to me. And the patient didn't remember having any previous CBC. So what do we do with this patient? If this comes in your clinic, what do you really do with a patient like that? So this patient, essentially, there is quite interesting or important information here. This patient should be diagnosed as constitutional or ethnic neutropenia. And you should not do anything further with this patient. You don't do anything more. And any extensive evaluation of this patient, or this patient of African descent, with any neutrophils count in this range, meaning more than 1,000, even in the absence of a past history of CBC, would be uninformative. You can make this patient spend a lot of money. We do a lot of other testing. It's unlikely that's going to present anything. Primarily, so here's the clues that here. This patient have mild neutropenia. Again, it's more than 1,000. We know patients, some ethnic conditions from African descent or Mediterranean, even some Mediterranean descent, they actually constitutionally they have a lower range. So this would be absolutely normal. This patient does not have infection. I mean, few sinusitis, we all get sinusitis infection all the time. So if you have a limited episode once a year and he didn't have it in the last 5 years, this patient is completely normal. So it's very important to recognize these variation, and you don't spend a lot more money on those patients. I remember seeing actually a patient, a pregnant patient, young patient, who presented with a neutropenia. The physician freaked out and actually wanted to get her into to go through a bone marrow. She was referred actually to a consultant because of that. And this patient had multiple reasons why she would be neutropenic. Again, we would observe the patient. I may repeat, in worst case scenario, I repeat it again in a week or in a couple of weeks to make sure that this is not going down, but more than I would not go any invasive there. So the next is an 80-year-old who presented with evaluation for neutropenia. This was incidental finding by the primary care physician 2 years earlier. Initially, it was mild, but steadily started to get worse over time. Recently, he had an episode of severe pharyngitis. On evaluation, was found to have absolute neutrophil count of 100. Subsequently, he developed a lot of skin lesions that demonstrated slow healing and required antibiotics. A bone marrow biopsy showed myeloid hypoplasia, but was otherwise unremarkable. This patient was started on methotrexate, and 4 weeks later, and his white blood cell count went up. So let's actually go through this case. What are the clues in the scenario before even we decide that we have to do a bone marrow, and we obviously were able to make the diagnosis in the bone marrow, which I'll explain to you what we found in a second, and you may predict what is that based on the therapy that was given. But the pattern of a recent and recurrent infection, severe infection, may help define both the duration and clinical significance of the neutropenia. So the onset of recurrent infection in a patient who previously enjoyed good health, since as seen in this patient, can help us to point out that neutropenia began 2 years ago. So really before 2 years, this is an 8-year-old. He started to get symptoms only when he was 78. So this is important to keep in mind, and also give insight on whether it reflects a serious illness or not. The fact that this patient is telling me had severe pharyngitis earlier, even without looking at CBC, I can tell this patient is going to have a low count in a setting like this. Why? Because recurrent infection in a patient with chronic neutropenia are uncommon illness. If the patient have more than 500, this patient already is telling me upfront that he have an earlier neutropenia diagnosed by the primary care 2 years ago. And he had neutropenia and now he's starting to get severe pharyngitis. He must have it below 500. In fact, usually seen only if it's before 200. So even I would know that this patient is very low. An infection syndrome of particular importance that happen in these kind of patients are pneumonia, sinusitis, pharyngitis, usually fever, usually nasal charge, and usually frequent dental caries and skin and soft tissue infection. So patient 2 actually was diagnosed. So when this happened, we know this is serious. We did a peripheral smear. We looked at the peripheral smear, and we couldn't find really what this happening, like what I showed you in the graph, the pathologist graph or diagram that I showed you earlier. And I recommended at this point to do a bone marrow biopsy. And the bone marrow biopsy showed decreased myeloid cells, myeloid hypoplasia. Everything else was normal. So we did some immune testing, and this patient was diagnosed with immune neutropenia. So, and based on this diagnosis, this patient was given methotrexate and 250 milligrams, 12.5 milligrams weekly. And 4 weeks later, his neutrophil count started to come up. So in a patient like this, I would have also suggested an LGL, but we specifically say we didn't see LGL in this patient. However, we tested this patient also for those, and they were negative. So this is how we basically go through the differential diagnosis, and we make we help you make the diagnosis for your patient. The third case is a 53-year-old woman who presented with an evaluation for neutropenia. She had been well previously. She had dealt with occasional sinusitis infection for many years. 8 months prior to her presentation, she was hospitalized for diverticulitis. During that admission, she was noted to be neutropenic, and her the neutrophil count was recovered since that. At that point, she had a 320 neutrophil count. The hemoglobin was slightly low, 11.3, and platelet was normal, 320. We did flow cytometry at that point, and we found no evidence of large granular lymphocytic leukemia. Why did we do that? Because again, in a setting like this, as I said, this is one of the things I may see large granular lymphocytes. I want to exclude that by flow cytometry. Bone marrow biopsy was formed and is completely normal and showed maturing trilineage hematopoiesis with myeloid predominance, but a little bit of left shift, and cytogenetics were completely normal. So what do we think is happening with this patient? If I bring the algorithm that I went through with you, that I create for myself, that I go through, exclude the process, I did everything I wanted to do, bone marrow, flow cytometry, I excluded LGL, sorry. I excluded I looked at the history and I didn't find drugs, medications. There is nothing to indicate she is 53. This is not congenital. So I have concluded everything. This patient essentially would be labeled with chronic idiopathic neutropenia. This puzzling symptoms required further studies to elucidate the pathogenesis, and really this is what we happen. So if I can't find, I keep going, but also I have to stop at some point. So these are the key things, knowing what are the key elements that we have to do, and at point we stop, and who do we stop with, and where we go next. So hopefully these three were examples. These are not inclusive, but just wanted to give you examples of how I put things together, again, to help the patient and the clinician to reach a diagnosis. Now, these are gonna, I put this algorithm together just to kind of summarize what I put, but from another view. It's actually from the clinical setting view. So a patient come with neutropenia, what's the first thing I do? I would ask the patient, I would ask myself, is the patient acutely ill or febrile? Does the patient have fever or acutely ill? If yes, then I have to admit. If it's less than 500, you have to admit to the hospital and you have to start him on empiric antibiotics. We still keep looking for the reason. If it's not, then we go to the next step. Or after I admit an antibiotic and evaluate, then I ask the question, is this a new onset? If the answer is no, it have been there before, like the case that I have shown you, I ask myself, is it ethnic? Is it familial? Or is it cyclic neutropenia? Some of the congenital things that have been there since this was a kid. If it is a new onset and there have no history, I look at when did it start? Is there a recent drug associated with taking this drug? Are there infectious exposure or not? And then if this becomes the case, if the answer is yes to any of those, I take the drug or I start treat the infection, or if it's severe, or if it's basically, in this case, it wouldn't be severe because it would be in the febrile if it was. But in this case, is it a viral infection that the patient is not febrile at this point? I look at, is it going to go on its own in a week or not? And if it went away, then this confirms that's actually a drug or infectious mediated. If no, then at this point I start to worry. I do an peripheral. I probably have to do the peripheral smears in any of those up front because it's cheap. It's actually simple. But if this doesn't resolve, then at this point I may have to do a bone marrow and flow cytometry to look at other things. If it does not resolve, I have to ask my question also in parallel: are there other cell lines involved or not? So are the patient have anemia and have thrombocytopenia or not? If they are, then I start think of nutritional, B12, folate. I test those. If it's not, then again, I go to perform the bone marrow. If the folate and B12 are normal, then I will do, again, the bone marrow. If the folate and 212 are abnormal, then basically are low, then I would diagnose the megaloblastic anemia and I treat accordingly. Now, once I do the bone marrow, there are three options, basically three outcomes that's going to happen. It's going to be simply one of those three. It's going to be some conditions that cause cytopenia, neoplasia, MDS, acute leukemia. There is going to be some neoplastic condition in the bone marrow, or the bone marrow is going to be is going to show other things like T cell abnormalities, or LGL is the most common one that's always in my mind with neutropenia. Or if none of those, the bone marrow comes normal, the bone marrow is normal, then it's normal, then you make the diagnosis of idiopathic neutropenia. You already know that. I'm not going to waste your time with this. Essentially, broad spectrum antibiotic, you have to diagnose the underlying cause, but you have to know what it is to be able to treat, and sometimes you may have to go GCSF. There's lymphopenia, lymphocytopenia, as I pointed out earlier. This is very rare, but you may have this in certain conditions. Again, this belongs to either acquired or hereditary, probably viral infections or AIDS, probably going to be the most common cause of monocytopenia you are likely to see, or some other dietary deficiency, alcohol abuse, or protein undernutrition or zinc deficiency. They are all some other iatrogenic causes could be there. But again, the hereditary ones, the Wiskett-Aldrich syndrome or ataxia telangiectasia, there are other clues for that as well. Monocytopenia, this is defined by monocytes being less than 500 per MCL, and basically, again, they can result from several conditions. They usually are transient and they are rare. This is the conclusion slide. Leukopenia, I hope we covered. This is a wide diversity of causes. Neutropenia is the most common cause of leukopenia, and we discussed that the approach from the lab side, basically, with how I think as a laboratorian, but I also need a good history and how bone marrow could be helpful, could be helpful, and these causes could be both plastic and non-plastic. And with that, I will stop and I will take any questions if you have. Sorry, I went a few minutes over.
متشكرين يا دكتور محمد جدا، احنا تعبنا حضرتك جامد واخرنا حضرتك. ايه يا جماعه، حد يسال اي سؤال يا شباب يا اخواني اللي داخلين معانا؟ حد عنده سؤال للدكتور محمد؟ مفيش حد بيسال يا دكتور محمد، واضح. بس طبعا هم عمالين يشكروا في حضرتك، يقول لك ثانك يو على المحاضره، وحضرتك يعني المحاضره كانت لطيفه جدا. حضرتك مشيت؟ لا ما مشيت.
لا انا موجود، سامع حضرتك.
ثانك يو على المحاضره، والمحاضره كانت لطيفه جدا. هم كلهم بيشكروك، مفيش حد عايز يسال اي حاجه، مفيش حد عايز يتكلم على الدكتور محمد في اي حاجه. وحضرتك ممكن تبعت البرزنتيشن لو حد يعني عايز يشوفها، يعني ياخدها.
هبعت البرزنتيشن وهبعت يعني اوكي، هبعت البرزنتيشن ان شاء الله. حاضر.
ابعتها لي حتى على الواتساب، او لو تحبي تاخد الميل بتاعي سهله قوي، ايمان نقطه الطحلاوي @gmail.com.
الاسم كامل يعني.
ايمان EMAN نقطه الطحلاوي ELTAHLAWY @gmail.com.
حاضر، هبعتها لحضرتك.
ماشي، شكرا دكتور محمد. طبعا انا متشكره جدا للناس اللي حضرت كلها. ثانك يو كلكم، وشكرا لكم على تعبكم، على مجهودكم ان انتوا حضرتوا معانا. انا مش عارفه اقول لكم ايه، ولو يعني تتشرفونا كده دايما وتنورونا وتدعموا المؤسسه، عايزينكم تدعموا المؤسسه دايما بحضوركم. في حد عنده سؤال؟ ثانيه. في حد كده الدكتوره داليا دفعتنا يا دكتور محمد، قلت لها حضرتك ثانك يو فيري ماتش على المحاضره. قلت لك هي استفادت منها جدا. في حد عايز يبعت اي حاجه تانية؟ حد عايز يقول اي حاجه تانية؟ شكرا جزيلا للدكتوره ابتسام، تقول لحضرتك شكرا جزيلا للدكتور محمد. كلهم بيشكروا حضرتك على المحاضره القيمه دي. والله انا يعني اول مره افهم الرسومات اللي بتبقى على اللي بتتبعت مع البلاد بيكتشرز دي، انا ما كنتش بفهمها خالص، مش فاهمه ايه اهميتها اساسا. فشكرا ليك والله يا دكتور محمد، كتر خيرك. ويا رب ده يكون مش اخر تعاون يعني بينك وبين المؤسسه، وحضرتك تستمر في دعم المؤسسه وتدينا محاضرات ثانيه.
ربنا يخليك. انا عينيا والله. يعني انا I'm just concerned ان انا يعني التوبيك not be very valuable. يعني انا I'm limited لاني I'm quite specialized يعني for what I do.
انا عارفه دكتور محمد ان انت سبيشالايزد في الدم، ودي حاجه لطيفه جدا، يعني حاجه ومطلوبه. ده ناس كتير ما بتبقاش عارفه تقرا ايفن الCBC بيكتشرز، دكاتره وما بيعرفوش يعرفوا معناها ايه، ولا كل حاجه معناها ايه. فاحنا متشكرين على المحاضره القيمه دي. وزها بتقول لحضرتك شكرا يا دكتور محمد. حضرتك بس احنا عايزين يعني تدينا وعد كده، يعني كل شهر محاضره على الاقل مثلا، ايه رايك؟
حاضر عينيا، بس انا ما اعرفش هلاقي توبكس تغطي ده لا، لان انا I was very selective في ده، ان انا حاجه ممكن تكون of value. فلو في توبكس يعني
والله انت كل اللي هتقوله حضرتك هيبقى ذو فاليو، ما تقلقش خالص من القصه دي. ماشي، ميرسي يا جماعه، وشكرا لكم كلكم. شكرا ليك يا دكتور محمد، مش هنعطل حضرتك اكتر من كده، عارفه حضرتك عندك ميعاد تاني. شكرا لحضرتك يا دكتور محمد، شكرا ليك. شكرا لحضرتك. شكرا لكل الحضور، شكرا لكم كلكم، واتمنى ان انتوا دايما تكونوا منورينا كده ومشرفينا يا جماعه. حد عايز يقول لي اي حاجه؟ فاهم؟ شكرا لكم كلكم.